Good afternoon. Welcome to UCLA and UCLA Ronald Reagan Medical Center. And my name is Dr. Isaac Yang, and I'm going to be giving a webinar today on meningiomas. And we're going to be talking about meningioma brain tumors. And if you'd like to follow along, we have a whole team here that's helping us do this on Twitter. And you can follow along at UCLA Health on Twitter. And you can also tweet with us at hashtag UCLAMDChat. We have a whole team on the Twitter page and on Twitter ready to respond to your questions. You can follow and ask questions to make this interactive. I'm really glad that you're here, and I'm glad that you're listening to this webinar. And this is a way for us here at UCLA and UCLA Neurosurgery to reach out beyond just this local area and to reach out beyond any time that you can watch this, because this webinar is available 24/7. It's always on the internet, and hopefully you can always contact us with any questions. And so today we're going to be talking about meningiomas, and I'm going to give an overview of this kind of brain tumor and how common this brain tumor is in people. And we're going to talk about treatment options. Do you need surgery? Can we treat with radiation, or do you need to have open surgery? I'm going to show a short video on surgery, and it's been edited, so it's not that gross, and you can see it and say, okay, that's meningioma brain tumor surgery. And lastly, I hope to touch upon some of the things that we do here at UCLA that helps us treat meningiomas as best as we can. So meningiomas are the second most common primary tumor of the brain in adults. It's a very common tumor, and it occurs between underneath the bone but above the brain, and it occurs on that spot on the dura. And so these tumors grow from the meninges, and hence it's called a meningioma. And they originate from these arachnoid cap cells, these cells between the brain and the bone. And so the meningiomas end up growing down into the brain, pushing the brain down. They are commonly slow growing. So you'll commonly hear the phrase that meningiomas are benign. And that means that they are rare to go into other parts of the body. So they don't spread from the brain to the chest or the foot very often. They don't spread like that, like cancer. So they call it benign. But I don't like that word benign, because this tumor, even though it's slow growing, in the wrong location, or if it grows long enough, even if it's benign, they can still cause a whole host of problems. And so we're going to talk about these meningiomas and what's the best way to treat them. A really interesting thing about meningiomas is that they are more common in women than men, about 2-to-1 ratio. And so meningiomas are more likely to occur in females, and we don't know the exact reason why. There's some hypotheses out there about estrogen or hormones, and it's not exactly clear why, but nonetheless, meningiomas are more likely to occur in women than in men. On the flip side, that doesn't mean it doesn't occur in men. Meningiomas still occur in men, and when they do occur in men, they are more likely to be atypical or malignant. The vast majority of meningiomas, they grow slow. A small subset of them, about 20% or less, they grow fast. And those fast-growing meningiomas, they're more likely to occur in men. Men still get the slow-growing ones as well, but that fast-growing, the smaller subset of meningiomas that grow faster, that are atypical and more malignant, they're more likely to occur in men. And that's just something to keep in mind when you think about it. And there are some risk factors, and this is what a common meningioma looks like. This is from one of my patients, and that you can see it's very bright, very white. It enhances with a lot of contrast, very homogeneously, which means the same. It's not speckled, it's one color, and it fills up with a lot of contrast. And there are some risk factors for meningiomas. One is a genetic mutation, and this is for neurofibromatosis, that if you have this disease, your risk for a meningioma is higher. Also, previous history of ionizing radiation. And we don't know, like I mentioned, whether sex hormones or head trauma are involved. The literature does not show any conclusive evidence, but there are theories that abound, especially because of the gender difference I mentioned earlier. And meningiomas are classified as either grade 1, grade 2, or grade 3. And the grade 1s, those are the ones that most people call benign. That's the appropriate word. They are slow-growing, benign tumors. They grow slow. And it's the best kind to have. It's a grade 1. But on the other side, 5% of them still recur within 5 years, even after you take the whole meningioma out. So when you have a brain tumor and you have a meningioma, it's not just a one-time thing. You're going to have a lifelong relationship with your neurosurgeon. We're not here at UCLA just to deal with the tumor and then be done. You're actually looking at having a lifelong relationship today and for the long run, because we're going to need to be in surveillance. Even after we treat the meningioma, we have to watch it carefully. Even after it looks like it's all out after surgery, we have to watch it for it carefully, because in some cases it comes back. And so this is a lifelong disease that we watch, and we watch carefully, even after we treat it completely. The atypical meningiomas, these are grade 2, and these are about 15 to 20% of all meningiomas, and these grow a little bit more quicker. So they're atypical, they grow a little quicker, and at the 5-year recurrence, about 40% of them come back. So the chance that these atypical meningiomas come back, it's much higher. And so it's really important for these atypicals, A, to watch them more carefully after surgery, and number 2, to seriously consider adjuvant radiation. Adjuvant just means plus. So you get surgery plus radiation, and you should seriously consider whether radiation is an appropriate add-on to surgery, because with the grade 2, the risk of the meningioma coming back, it's a lot higher. And then lastly, the worst kind of meningioma to have is a grade 3, and these are called anaplastic meningiomas, and they occur at about 1 to 3%. And these meningiomas have a very, very high chance of recurrence. And so for these, you absolutely need to have surgery and follow that with radiation and everything you can throw at it. But just because you have a meningioma, just because you have a brain tumor, does that mean you have to have brain surgery? I'm a neurosurgeon. This is my specialty. This is what I focus on, is brain tumors. And I'm here to tell you that just because you have a brain tumor doesn't mean that you need to have surgery. And I know that's really kind of the best news you could hear. If you go to a neurosurgeon or you go to a brain tumor surgeon, the best kind of news you really want to hear is you don't have to have surgery. Observation is absolutely a possible role for meningiomas. They're slow-growing benign tumors. If they're slow growing, if they're small and asymptomatic, we may be able to get away with just watching them. Just because you have a brain tumor doesn't mean that you need to have surgery. And so if this is possible, we're going to try to do this. And I call this sometimes less is more. If there's a small tumor and the size is about less than 2.5 centimeters, and that varies, it depends on the exact location. It's a generalization, but approximately 2.5 centimeters if it's that small. If we've been watching it year after year with MRIs and it's not growing and it's not causing any symptoms, this may be something you may want to watch, especially if you're elderly, if you're 50, 60, 70, or 80, and you have a lot of medical comorbidities. It may be something to watch. And observation is absolutely a pathway. Now, if you're young or if the tumor is large, then observation is probably not the best pathway, and surgery or radiation is something that needs to be considered. And that surgery is favored in patients who are young or in patients that have very large tumors. And this is a case of a very small asymptomatic meningioma from one of my patients. You can see here's the meningioma. It's small. It's in the area that it's pushing the brain a little bit, but it's not causing any edema. The patient didn't know that they had this. They found this on accident. It was an incidental finding, and you find these after car accidents. And so they didn't know they had it. They found it, and they were told they had a brain tumor, and they came and saw me, and we advised not to do surgery, that we watch this, that if it's an asymptomatic, small meningioma, that you can watch this. And this is not just UCLA's approach. This is not just the way we approach meningiomas or my advice. This is what's also in the literature. If you do the scientific literature search, this is a paper from Harvard looking at the SEER database for meningiomas. They looked at over 12,000 patients with meningiomas across the country. And in this breakdown, they found that 47% had no surgery or just a biopsy of their meningioma. So a high percentage of their meningiomas were not treated but followed with serial imaging. And I believe that's a valid option course. It's something to discuss with your neurosurgeon to see if that's something that can be done. Because if you can avoid surgery, it's something that you want to think about. That's something that can be done. And this is the breakdown of that entire patient list. Here you see the 3,844 female patients with surgery and about 1,000 that did not have surgery. And the breakdown is less than that because, again, meningiomas are more common in women than in men. There's less men in this cohort. And they looked at the 1-year survival and the 3-year survival. And it's over 90% in the 1-year survival and over 94, 91 in the 3-year survival. And in the group here with no resection, it's about 81% in the male group. And that always makes me think about the fact that in men are more likely to have meningiomas that are atypical or more aggressive. And so that's something to think about when we treat patients. The other option and development that we have now is radiation. And we call this stereotactic radiosurgery or stereotactic radiotherapy. And although they're called different things and you'll hear different names like gamma knife and linear accelerator and cyberknife, basically this is focused radiation. Focused radiation that treats the tumor and leaves the rest of the brain tissue alone. And this is a fantastic option that if you have a smaller tumor and you don't want to have surgery and this tumor needs to be treated, that radiation is a fantastic option that doesn't require an incision. There's no pain in terms of anything having to go into your head. This is no incision, no recovery time. You come and get the radiation and then you're allowed to go home. And this is a fantastic option for smaller meningiomas. And this is a way that we can treat tumors and meningiomas with radiosurgery, especially when they're smaller. And this is a paper from Dr. Zada looking at meningiomas that were treated with radiosurgery. And this is looking at benign meningiomas and progression-free survival. And you can see that these patients, almost 80% of patients in the long term have tumor control and excellent progression-free survival. And they say that the 5-year and 10-year progression-free survival rates were 99% and 84%. And these were tumors that were treated with radiosurgery preemptively. And in this particular paper, they didn't do a biopsy. They looked at the MRI. They made the presumptive diagnosis of meningioma and went ahead and treated these with radiation. So it was a very effective treatment option. And so these are the treatment options that are available. You go see a neurosurgeon and you see a surgeon and you think they're going to say surgery. And for these benign tumors, the response has to be surgery or maybe observation or maybe radiation or maybe some combination of those 2 or 3. And that actually has to be the things that we need to discuss about meningiomas. Can you treat them with radiosurgery or stereotactic radiation? Can you follow them? Do you have to have surgery? Or is this a small meningioma that's asymptomatic and not causing problems? Is it something that you can watch? These are always options and they have to be discussed. And how do we decide what's the best one? Well, it's not just like a cookie cutter paradigm. You can't just treat every meningioma patient the same. Every person is different, and every person has a different tumor. And so based on each patient, based on their goals of care and their age, everyone's care has to be individually tailored. It's the era of individualized medicine that based on every single patient, whether or not they want to have surgery or they don't want to have surgery, how their risk tolerance is to radiation, what their risk tolerance is to observation, and how they feel about getting an MRI every year. But no matter which option or course you decide to take or your loved one decides to take, when you have a meningioma and you're being treated with a meningioma, this is a lifelong disease that even after successful surgery or radiation, you need to follow these with serial imaging because there's a small chance that the meningioma can always come back or keep growing. And so this is a lifelong relationship. We are here for the long term. This is a long-term relationship that we are starting looking at how to treat these meningiomas. But sometimes when the tumor is really big, or if you're young, or if the tumor is causing a lot of pressure or edema, or it's causing problems, you're going to need to have surgery. And so that's what we do here. We do open microneurosurgery with a microscope. We do open microneurosurgery to do the smallest craniotomy that we can do. We try to do a minimally invasive, maximally effective resection of tumors. And we do our best to treat these tumors in the best way with surgery. Now this is from a paper by Dr. Shagru looking at a very large meningioma. And again, here's that homogeneously enhancing. It enhances the same. Lots of white. And you can see this tumor right here in the middle. And it's very large. And this is in this paper published by Dr. Shagru. And the amazing thing about this was this patient's vision. This patient was losing vision. This large tumor was causing pressure on the patient's optic nerves, and so the patient was losing vision. And so this was the patient's visual field test, and here you can see that there was some visual loss here and some visual loss here, and so the patient was getting ready for surgery, and then the patient all of a sudden went completely blind in the patient's right eye. Completely lost vision. This was an emergency. As soon as the neurological sequelae and the neurological symptoms occur, you want to get these treated. The sooner the better. And so here you see that the patient went completely blind in the patient's right eye. The patient was taken emergently to surgery. And here you can see that the meningioma had an excellent resection, that the meningioma was taken out through surgery. And after surgery, you can see that the patient's vision got better. So this is the patient's vision at presentation. This is the patient's right eye that went blind. The black spot represents that the patient was losing vision in the right eye. And then after surgery, the patient's vision got better. And so if you're having a neurological sequelae, you absolutely need to think about surgery, because surgery decompresses the nerve, decompresses the brain, and in those situations where things are getting worse, surgery is the fastest, quickest, best way to try to make things get better again. Now, if you have to have surgery, I've been asked what's it look like, and we have a short clip, about 15 seconds, of a meningioma surgery. This is a meningioma surgery that I did, that we resected the tumor and that we got it out, and you can see us taking out the meningioma. We're going to have a longer version of this, and we'll throw it up on the web if you want to see the longer version of this later. Oops. Here you go. And so here, this is the tumor right here. And this is a small craniotomy that we did right around it, and you can see the brain tissue that's around it. And what we're doing here is just dissecting the very last few fibers off the meningioma where it's connected. And here you can see that we remove the meningioma in its entirety. And that's the meningioma surgery. That's what it is to do open microneurosurgery. And that was with a camera that was attached to the microscope into looking into the surgical field. The other thing to look for when you look at meningiomas is the swelling around the tumor. Here you can see the small white tumor, and this is a paper published by Dr. Chi, that you can see a small white tumor here, but around the tumor you see a lot of white on T2 or flare. And that means there's a lot of swelling. And so even if you have a small tumor, or if it's not symptomatic, or if it's causing problems, if the brain has a lot of swelling around the tumor, that's concerning. That makes me want to recommend surgery more than any other option. If you have a lot of swelling, that may also make radiation not an option. And so this is something to consider, is how much swelling does the brain have around the meningioma. So here you can see an example of moderate edema, a little bit of swelling around this. And here you can see evidence of severe edema, lots of swelling on both sides of the brain around the meningioma. And so this is one thing that's an important consideration. Like I said, every patient is different. Every meningioma is different. And so every patient needs individualized care. What's specific to them? And you want to look at whether or not that tumor has a lot of edema, because every person's care will be different based on these factors. And here you can see more evidence of, here's the tumor again, and here's the moderate edema, a little bit of white around the tumor on the T2 or flare, and here's severe edema, lots of white on the T2 and flare around the tumor. And these edema can sometimes cause problems, that sometimes the tumor itself isn't the one that caused problems, it's the edema around that. And that these problems that are caused by tumors, a lot of the times, not every time, but a lot of the times, surgery can help make them better by decompressing those nerves. And this is what this table shows. When we look at meningiomas, and we look at meningioma surgery, like the example of that surgery we did, and in surgical scientific speak, we would call that a Simpson grade 1 resection, where we resected the entire tumor and resected the covering meninges, or the dura, around that tumor. And we have a grading scale for this surgery. It's called Simpson grading scale. And you'll hear this when it comes down to meningiomas. And it's graded into 5 grades, 1, 2, 3, 4, and 5. A grade 1 Simpson meningioma means that we got the entire tumor out with surgery and including the dura. And that each layer down you get less and less and less. And a Simpson grade 5 resection is just a biopsy of the meningioma. And so there are 5 grading scales. You don't have to know the details of the Simpson grading scale, but the reason why I bring this up is that this here, and this is a paper from that same paper from Dr. Chagruz, is that this looks at the recurrence rate based on the Simpson grade. And so remember, we said Simpson grade 1 is where you get the entire tumor out. The entire tumor is resected, including the dura and the meninges around there. So we do a Simpson grade 1 resection, and at the 5-year post-surgery time, the recurrence rate is about 3.5%, about 4%. So even in the case where the entire tumor is taken out, all the dura is resected, you get the best resection you can get, a Simpson grade 1, like in that patient that I showed you. In that video, we got the entire tumor out, Simpson grade 1. At 5 years, there's still a 4% chance that the tumor will come back. And at 15 years, there's still a 7 to 10% chance that that tumor will come back. So there's a 90 to 95% chance that that tumor will never come back. But that patient, she still follows with me because it's a long-term relationship. We're looking at the 5, the 10, the 15-year follow-up because there's a small subset, 10%, 5%, a small subset. And if you're in the 90%, that's great. We'll see you once a year, every few years, and we'll follow the meningioma on MRI. But if you're in that 5 to 10%, it's my job. That's my job to worry about those 5 to 10%. It's my job to worry about the worst case scenario. It's my job to think about the long-term scenario, the long-term relationship, and that we need to follow for that rate. Because even in the Simpson 1, you see that number there, it's something to consider, that there's a chance that they can recur. And as you get down to less of a surgery, the Simpson grade 5, the chance for recurrence is much higher, 36% at 5 years and 63 to 100% at 15 years. That the chance for recurrence and more tumor growth, it gets higher and higher with that meningioma. And so we need to look at these and see how are these treated. And this is based on the Simpson scale and looking at tumor recurrence. And if the tumor recurs, do we still have other options? Do you need surgery again? And we go through the same algorithm again. Is it small and asymptomatic? Can we treat with radiation? Has it had previous radiation and cannot be treated now, so it needs surgery? Or is it large, or are you young? And if it's large and young and causing a lot of problems, then maybe surgery is the option. Or is this something on a first-time diagnosis that we watch? And so we go through the whole algorithm again in terms of the recurrence and watching out for recurrence. So it's a lifelong thing. And this is a patient of mine that had a giant meningioma. You can see, again, the white here on the MRI, it's the same color. They call this homogeneously enhancing. You'll see it's the same color filling with white. It's at the very top here, and it's pushing down on the brain. You can see the brain being pushed down. And this tumor actually has a fair amount of edema. And you can see this is the same tumor looking at it from the side. And you can see here that here's the tumor, and that this tumor has some calcifications in it. It's very large, and it's been pushing down. And because this tumor is large, we had to do surgery and take it out. And this is a picture of that exact tumor at surgery. And here you can see this is the tumor, and this is the brain. It's pushed the brain to this side. And what we do in surgery, and this is with a bipolar, it's a special microsurgical instrument that we use in the OR. Essentially what we do with this is we stop the blood supply to the tumor. It's the first thing we do when we take out meningiomas, is we stop the blood supply to the tumor. If you start taking out the meningioma before the blood supply to the tumor is gone, that meningioma will bleed. But if you strangle the meningioma, if you starve it of blood, and you take out the blood supply to the tumor, then the tumor will not bleed when it comes out, and it makes the surgery much different. We can also do this with neurointerventional angiograms, that sometimes we embolize tumors. We have, just like how they do procedures to the heart through the groin, well, they can do the same thing to the brain through the groin, and if they see the blood supply, before surgery with interventional radiology here at UCLA and neuro-IR, we can embolize the tumor. We can strangulate the tumor. We can starve it of blood so that when we take the tumor out, it doesn't bleed. And this is the MRI of that exact same patient with that giant meningioma after surgery. And here you can see this is where the tumor used to be. And here the tumor is now completely gone, that we've resected this tumor in its entirety. And that's the space where the tumor used to be. And so here that's an excellent resection, and that's a decompression of the brain, and we give the brain a lot of space by taking it out. The next thing we do is that we take that tumor, we slice it, and we give it to pathology, and they look at it under the microscope, and this is a picture of that exact tumor that we took out. So you saw the pre-op MRI, you saw the pictures of the actual tumor, you saw the post-op MRI. This is the actual pathology of that tumor, and this final pathology report reports that this is a WHO grade 1, World Health Organization, grade 1, and like we talked about before, grade 1 is the most common, up to 80% of meningiomas. They're the ones we call benign. And that this was a fibrous meningioma. And that's a really good diagnosis to have for that tumor. And the kinds of meningiomas that are grade 1 are the meningothelial, the fibrous, and the transitional. These are the words that we use to describe the kinds of meningiomas that are grade 1. Grade 2 meningiomas are atypical, clear cell, or chordoid-like. And that grade 3 are the rhabdoids, the papillary, and the anaplastic. And these grade 3s are only about 1 to 3% of meningiomas, but they have a very high rate of recurrence. And these are the ones that we want to take out. The last thing I want to mention about atypical and malignant meningiomas is that if you have an atypical meningioma, which is, again, 15 to 20% of meningiomas, their rate for recurrence is much higher than with a grade 1 benign meningioma. And that Simpson classification that we talked about only applied to the grade 1 meningiomas. If you have a grade 2 meningioma, the chance of recurrence, or a grade 3 meningioma, the chance of recurrence is much higher. So if you have an atypical meningioma, it's something seriously to consider is whether or not you also treat not just with surgery, but with radiation to the resection cavity. That we treat with radiation on top of surgery. That you treat, because atypicals and malignant meningiomas, grade 2s and grade 3s, have such a high rate of the tumor coming back, you throw everything you have at it. You throw surgery at it, plus radiation, because you want to try to minimize its chance of coming back for as long as possible. And I want to remind you, we have a whole team here. They're working furiously away that if you have questions, that on Twitter at UCLAMDChat, as well as UCLA Health, where you can follow, you can ask questions. But it looks like they're very busy on that. And so this is looking at the atypical and malignant meningiomas, and this graph just shows that they're at a higher rate to come back. Like I said, the grade 1s are slow growing and benign. The grade 2s and the grade 3s have a much higher rate of recurrence. And so these are the ones that we want to be concerned about. Well, what causes meningiomas? What are the genetics that are involved with meningiomas? Well, we talked about this in that neurofibromatosis 2, the tumor suppressor Merlin, is on this chromosome monosomy 22, that this mutation increases your risk for meningiomas. And that in 70 to 80% of fibroblastic and transitional meningiomas, they have this genetic mutation. But the atypical and the malignant meningiomas also have this mutation. So this mutation is probably very important for developing meningiomas, but it's probably not important in distinguishing grade 1 versus grade 2 or grade 3 meningiomas. Atypical meningiomas, WHO grade 2, a lot of them, more than half of them, have a deletion on chromosome 1. Whereas in WHO grade 3 meningiomas, 90% of them have a mutation on chromosome 1. So this chromosome 1, although we don't know exactly how it causes meningiomas, are important in distinguishing more atypicals and grade 3s. And that this 1p14q deletion, this has been associated with a worse prognosis. And so these genetics, although they don't help us define what causes the meningiomas just yet, they're actually useful in determining the prognosis for meningiomas. And this is something that's useful to do in treating meningiomas. And so that's how we can treat meningiomas. That if you have an atypical meningioma or a malignant meningioma, that we treat them beyond just the surgery, that you treat them with radiation and also look at their genetics to evaluate their prognosis. So meningioma treatment options are 3. The first one, sometimes less is more. You go to a surgeon, you go to a brain tumor surgeon, you're expecting to hear you need surgery. But the best news you could hear is, actually, you don't need surgery. Sometimes less is more. We just need to do watchful waiting. Can we keep watching it? The second option is radiation or radiosurgery. You need treatment, but you don't need surgery just yet. That's the second best news. Is this tumor small, and can we treat this with radiation? And then lastly, if it's young, if you're young, or the tumor is large, or if it's causing problems, we can do surgery. And we can do surgery to take the tumor out, or take out as much as we safely can and treat the residual with radiation. And if it's an atypical or malignant, we have to strongly consider radiation, because the chance that those tumors come back are much higher. We're doing research here at UCLA on meningiomas as well. We currently have an allo-CTL immunotherapy trial where we are investigating the use of your immune cells to fight meningiomas that come back. And so this is immunotherapy for meningiomas. We also have an IRB, an Institutional Review Board approved study, looking at the UCLA institutional experience with meningiomas. We are looking at all the meningiomas we've treated here at UCLA. We've been here a long time. We've treated a lot of meningiomas. we're looking at all the meningiomas we've treated, either with surgery or radiation, to see how those patients do. And so we have these studies going on. And lastly, to put a plug, we have a strong presence at the Meningioma Symposium that's coming up this Friday and Saturday in New Orleans at the AANS Tumor Satellite Symposium. I'm actually one of the co-scientific program chairs for this meeting, and this is looking at the meningiomas that we treat in the whole country. It's where all the world's experts in meningiomas gather together to talk about this, and it's happening this Friday and Saturday in New Orleans, April 26th and 27th. And we looked at this, and we published our results here, and this is in the Journal of Skull Base, looking at the long-term clinical and surgical outcomes of patients with intracranial meningiomas. This was done by Dr. Winward Choi, who presented this data, and looked at complications, looked at tumor resections, and looked at how we can optimize the quality of life for our patients and optimize the quality of our surgery. The other option that you can treat meningiomas with is with radiation. You can do radiosurgery or radiotherapy, stereotactic focused beams of radiation. And because you come and get these, there's a very low risk of side effects from radiation, because you come get the therapy and you go home. You go home and have dinner and you're just fine. And there's a very low risk of complications with radiation. It's a different risk profile than surgery. This I just got straight off the New York Times. It's on Google. Everything's on the internet these days. You can Google this. It's on the New York Times, and it looks at a pinpoint beam strays invisibly, harming instead of healing. It was an article in the New York Times about radiosurgery, about radiotherapy, and that just because it's radiosurgery, you can't take it lightly. You can't just say, it's just radiosurgery, and very few people get hurt, and so we don't have to worry about it. In my opinion, radiosurgery is just like real surgery in that experience, quality of the institution, and the quality of the program and the history of the program with the experience there actually makes a big difference. That you want to look at the safety protocols. You want to make sure that they have those safety protocols, those quality initiatives in place. And at UCLA, we take this extremely seriously. That neurosurgery, we're actually one of the leaders in the quality initiative here at UCLA. That neurosurgery helps to focus on quality and quality of life, and looking at these things to make sure that radiosurgery is done safely and effectively, and that these things should be done at high volume radiosurgery centers, because they have more of the infrastructures in place, and that if you do radiosurgery or radiation, and if you have problems with radiation and radiosurgery, you can still cause a lot of problems, because people have this misconception that radiation can't cause problems, and it's out there, it's public knowledge that if you do the radiosurgery or you do the radiotherapy in the wrong way, you still can have problems, and this is something to think about. And I think this is the thing that helps set UCLA apart. One, we have an expert team of neuro-IR doctors. We have neurosurgeons that also do the embolization, and that's their focus, that they do the embolization. We have interventional radiologists that also do the embolization, and that's their focus. They just treat with the embolization. Then we have surgeons that also just do the surgery, like myself. I'm a neurosurgeon, and we do open microneurosurgery. We do the surgery, we do the cutting, and we resect the tumor. We also have an expert team of radiation oncologists, doctors who help us treat these tumors with radiation. And that this multidisciplinary team, having experts in different areas working together, makes this really effective, safe, good quality of life way to do that. And this is one of the things that I think are really important, that having expert radiosurgeons that help see this, that do a lot of radiosurgery, they help make our treatments better and safer for our patients. And that we have this centralized radiation review, that we look at tumors and that we look at them at our weekly radiosurgery tumor board, that we look at meningiomas, and every tumor that gets treated with radiosurgery, every meningioma that's going to get treated with radiosurgery is going to get reviewed, and that I'm part of that team that helps review it, and that we look at this every Wednesday at our radiosurgery tumor board. And that this is really the future. If that one day we can research our way out of surgery and research our way out of radiation, we can develop some better algorithm, that would be the future. Is that we are looking at the molecular and genetic profiling of tumors. That we take these tumors and we look at their slides, and that we can look at the specific genetic and protein markers that are different on all of these tumors, and that one day this will allow us to create better therapies, better treatments, have a better idea of prognosis, how these patients are going to do, and have a better way to attack these tumors. And this is the research that we're doing here at UCLA. This is a paper that was published by Dr. Yu from our laboratory. It looked at chromosomal alterations, prognostic factors, and molecular therapies for the atypical meningiomas, the malignant meningiomas, the ones that keep coming back. These are going to be more aggressive. We need to be looking for other prognostic factors, the molecular alterations, the genetic alterations in these tumors, that the future in these things are going to be done on a genetic protein level, and that looking at this will help us treat this. And we are doing this here at UCLA. And that this multidisciplinary care, multiple experts coming together, working together, in my opinion, yields the best care for meningiomas. And that we try to tailor everyone's care. We know everyone is different. Every person is different. Every family is different. And that makes every meningioma that occurs in that patient different for the scenario based on the personality, their situation in life, their gender, and that every tumor needs personalized, every patient needs individualized and personalized care for that tumor, because we're trying to create different outcomes based on different goals, and that every single time that we do the safest, most effective, most minimally invasive, most appropriate, safe and effective care for our patients with meningiomas. And that we add on top of this world-class and cutting-edge research to look at the genetics, the proteins, the molecular markers, and the future research based on patients, based on tumors, and clinical outcomes is what we're doing. And that this is high-tech, advanced, life-altering neurosurgery. That we do this with compassion, that we connect with our patients, and we do this with utmost healing. And I call this never neurosurgery as usual, or never medicine as usual. And success is a team sport. We do not do this alone. These are all the members of our lab here, as well as the UCLA Brain Tumor Lab. And I want to point out Andy Trang, Nolan Ung, and Kim Phil, recent additions to the lab, who also helped me put these slides together. And that the UCLA Brain Tumor Program here at UCLA is a big program. It's multidisciplinary. And there's a huge team of us that help do this. There's Dr. Neil Martin, Dr. Marvin Bergschneider, Dr. Linda Liao, Dr. Bob Schaffa, and myself, all part of the brain tumor team here at UCLA, and that we, as part of the brain tumor team of the UCLA Neurosurgery Department, we are experts in brain tumors and on how to treat all kinds of brain tumors, including meningiomas. We also have an excellent neuro-oncology team with Dr. Clausey and his group, as well as colleagues in radiology, pathology, ENT, and colleagues in radiation oncology. And like I said, we have an expert multidisciplinary team. And I have to thank sources of my funding, including a Stop Cancer grant, a Stein-Oppenheimer grant, that these grants allow me to do my clinical work, to take care of patients, as well as to do meningioma research. And lastly, if you have any questions, feel free to contact me. You can Twitter us right now, like I said, or you can call our office. You can email me. You can Facebook message me at Isaac Yang UCLA Neurosurgery. I'm also on Instagram and Google Plus as Isaac Yang, and then Twitter here at UCLAMDChat, that we're always available for open-end questions. And I'm going to talk to our team here to see what questions we have now. Oh, there's a lot of questions. Okay, super. So I guess there's a lot of people watching. That's fantastic. We're gonna start off with a few of these questions. Number one. If I have a meningioma, are there activities that I should not participate in? That really, like I said, every patient's different, every tumor is different, and this is based on what size your tumor is and whether or not it's causing any problems. If your tumor is large and it's causing problems, the best treatment would be to get treatment, to see a neurosurgeon or a neuro-oncologist, and to look at your options for treating it. If you have a small asymptomatic meningioma, it's not causing problems, it's less than 2 centimeters, and it's growing slowly, and you've seen a neurosurgeon and they decided that you don't need to have surgery, then I think you can pretty much be on the other side, which is live a normal, healthy life, control your blood pressure, eat a healthy diet, exercise. But besides that, I think you're allowed to participate in all the normal activities of daily life. Number two, are there any alternative treatments for meningiomas? And I think by this you're asking, are there any Eastern medicine or alternative therapies like acupuncture? And I think those treatments are fantastic, especially for helping with, we didn't talk about this, but having a brain tumor is stressful. Having to see doctors is stressful. Having to go through this. And we try to minimize that here at UCLA. We want to minimize the stress. We want to maximize quality of life. We want to make this as pleasant an experience as possible, but nonetheless, there's just no way to make that zero. It's going to be a stressful experience. You're going to have anxiety. I think those options are very, very good. I always recommend things like yoga, meditation, prayer, acupuncture. As long as the acupuncture is away from the site of the surgery, I think those things are fantastic. I don't like chiropractic in the upper cervical spine of the neck. It makes me a little bit nervous. But chiropractor of the chest and of the lower back, I think that's a good idea. I like massage. I like meditation, yoga, prayer. Anything that you want to do on the alternative therapies, I think they're very good for helping deal with the psychological sides of meningioma. Now, do I think that they will be effective in keeping the meningioma the same size? Well, a lot of these meningiomas, they don't grow, or they grow very, very slowly. And so that might happen no matter what. But if you believe and think that those will be helpful, I think those are fine. But I don't think that these therapies will be all that effective in causing the meningioma to shrink. If the meningioma changes in size very, very quickly, I'm concerned that if it grows, that's more malignant or aggressive. And if it shrinks very quickly, I'm concerned that's not a meningioma. And so I wouldn't expect those alternative therapies to shrink the meningiomas, but I don't discourage them. One area I do discourage them in is that if they're very expensive, or if you cannot afford them, I'm reluctant to say to try them, because I don't want them to be too expensive, and I don't want you paying a lot out of pocket for therapies that may not be all that effective. I've read that meningiomas are more common in women. Is there any chance that this tumor is related to breast cancer or the treatment for breast cancer? Meningiomas are more common in women, and so there's a question whether or not they're related to hormones. And we don't know the exact role that hormones play in breast cancer either. There's no direct link between breast cancer and meningiomas. When I see a patient who's had breast cancer or is a breast cancer survivor and has a meningioma now, a newly diagnosed one, I'm a little bit concerned that it could be a meningioma, but I also want to make sure it's not a dural-based metastases. Sometimes other cancers can mimic meningiomas by growing to the dura, and that makes me concerned. I want to make sure that it's not that. There's no direct relationship between breast cancer and meningiomas, but meningiomas can be caused by radiation. And so sometimes we see this in children who have other kinds of cancer. And if they're treated with radiation and the radiation hits their brain and hits their skull, that when they're much older, when they become adults, 10, 15, 20 years later, they have radiation-induced meningiomas. And that's a known risk factor for that. And so that's something to consider. But there's no direct evidence between breast cancer and meningiomas. Excuse me, I'm just going to take a quick. Do meningiomas cause memory problems? Meningiomas by themselves do not cause memory problems. They do cause memory problems when they're growing near the memory portion of your brain, if they're growing near the temporal lobe or your hippocampus. And then on top of that, if those organs, if those portions of the brain have the edema, remember we saw that, the T2, flare, hyperintensity, the white stuff on those portions, then yes, they can cause more problems and possibly cause memory problems. But the vast majority of meningiomas, I would say, are not going to cause those problems. How long will it take to recover from surgery for meningiomas? Well, that depends on the size of the meningioma. Like we said, every meningioma is different. Depends on the size, the location of the tumor. And so based on the tumor and the size of the meningioma, this answer is going to vary. And some of these meningiomas, they can be up and about and out of the hospital in 1 or 2 days and back to work in just a few days after that. Other sets of meningiomas, because they're much larger, can be in the hospital 5 to 7 days and back to work weeks after that. And that really depends on the size of the meningioma, the location of the meningioma, and the surgery to take it out. Another question is, I have headaches all the time. Could it be a meningioma? Maybe. The best and only way really to diagnose a meningioma is with an MRI, and the best MRI is an MRI with and without contrast. and that this MRI can help you see whether or not you have a meningioma. That a lot of patients don't know they have meningioma, so we find meningiomas that are found on accident. People have a car accident or they fall down and they get a CT scan and they were found to have a meningioma. And in those patients, if they are, the tumor is small, asymptomatic, and the patient is older, then in those patients, we're going to follow them. They don't need to have surgery. They didn't even know they had the tumor until they had the accident. And so it's a small, asymptomatic, not causing any problems. In those patients, maybe observation could be a very good step for those patients. Are there any clinical trials that I can sign up for meningiomas? Well, like I mentioned, we currently have an immunotherapy for recurrent meningiomas. That in these patients where the meningios are coming back, we are utilizing immune cells, your immune system, and trying to utilize the immune system to help stop the meningiomas and fight the meningiomas. Who are more likely to develop a meningioma? More likely to develop a meningioma, like we mentioned, they're more likely to occur in women versus men. So meningiomas are almost twice more common in women than in men, but that doesn't mean that it doesn't occur in men. They do occur in men, and when they do, those meningiomas in men have a higher chance or higher rate of being atypical or malignant, being that 1 to 20%, that's the kind that you really don't want to have for meningiomas, that they have a higher rate of recurrence. And so that's very something to think about. This is a question that just came in. I'm wondering if you would mention why a craniotomy would be a preferred approach to a 2-centimeter meningioma that sits approximately behind my right eye and is beginning to encapsulate cranial nerves 6 and 7 near the cavernous sinus versus an endoscopic approach. That's a really good question. And like I said, every tumor is different. And you mentioned that your meningioma is about 2 centimeters. And so you could say, well, it's in that group, it's 2 centimeters, you could just watch. Well, I don't know your age, so you're not mentioning your age, but it's 2 centimeters and it's near, right behind the right eye. So all of a sudden, it's a different picture in that this tumor is near cranial nerves. It's near the nerves for vision, it's near the cavernous sinus, it's near the cranial nerve 6 or 7. So if the tumor is pushing on those nerves, this is no longer a small asymptomatic meningioma. This is a small and symptomatic meningioma. So even though it's small, it's causing problems or has the potential to cause a lot of problems because of its location. And so every tumor is different. This helps prove that every person is different and every person's tumor is different. That every tumor is different based on the size of the tumor, the age of the patient, and here, location. Like I mentioned, the location of the tumor helps dictate how quickly you can recover, what the average recovery is like, whether you can be out of here in 1 or 2 days or be out of here in 5 to 7 days. That the location of the tumor is very important. And so your location of the tumor is near these important nerves. And so the approach is, should you have a craniotomy versus an endoscopic approach? Well, this is based on whether or not how the tumor should be approached. Should this be approached with an open surgery and craniotomy, or can this be taken out with an endoscopic approach? And that's really based on the location of the tumor. That some tumors can be best approached through the nose. And we have a world expert in this, Dr. Marvin Bergsnyder. He's an endoscopic expert that can go through the nose and take out these tumors through the nose. Other tumors can be taken out through surgery on other different portions above the brain and below the tentorium in other locations. And sometimes those can be done through an endoscope. Other times, they're going to be taken out through with a microscope. And so through the nose, through a microscope, there are other neurosurgeons that can do that and do this as well, or do a microscope through the other portion of the brain. And so this is what you're asking is there any reason why a preferred approach is done with a craniotomy versus an endoscopy? And without looking at your exact MRI, I can't push down to one specific approach to take this in or take it out. And the next question is related, is cranial versus endoscopic approach. Your thoughts, Dr. Yang? I think the most important approach is not to have a generalization. I think the most important answer is not to say cookie cutter. Craniotomy is always the best answer. Cookie cutter. Endoscopy is always the best answer. Cookie cutter. Going through this or that is always the best answer. Every meningioma is different, and every patient is different. And so because of that, every person needs individualized recommendation. I do have one generalization, which is that every patient should try to have the minimally invasive, maximally effective approach. You should try to have the smallest surgery possible, or you should try not to have surgery at all. And if you can observe it, that's great. If you can treat with radiation, that's better, and you can avoid surgery. Or if you need to ultimately have surgery, whether you need to have a craniotomy or whether you need to have an endoscopy, I think it comes down to trying to do the best approach, the best surgery, the safest surgery, the most effective surgery. And so if you say, look, I want to have the smallest surgery possible and just do a really small incision, but if it's not effective and if it's not going to take the tumor out, that's not the surgery I can recommend. That just because it's minimally invasive, if it's minimally effective, that's not a good thing. We want to do the minimally invasive but maximally effective. So we want to do the smallest surgery we need to do, but the one that will get the job done. And so my recommendation is to do the surgery, the safest surgery, the best surgery, the one with the best quality of life, and to do that in the most minimally invasive way possible with the biggest effect possible. Maximally effective, minimally invasive. And so if you need to do a larger surgery or a larger craniotomy in order to have more effect that's safer and more effective, then that's what I recommend. Or if you can do this in a smaller incision or with a smaller craniotomy, and that's just as effective, then I'm going to recommend that as well. I'm going to recommend that over. You want to do the best surgery for each patient every single time, and that varies based on each patient and each tumor. And I think that's it. There's a whole host of other questions, but I think we're running out of time. If you have any other questions, feel free to email me, Facebook me, Google+, Twitter. We're on Twitter right now with UCLA MD Health. We're also on the UCLA MD Chat, and we're also on the internet. I'll throw up a longer version of that meningioma surgery up on the internet, and you can always contact us here at UCLA. It's been my absolute pleasure to be here and discuss brain tumors. Again, my name is Isaac Yang. I'm a neurosurgeon here at UCLA. My specialty is in brain tumors. We have an outstanding, multidisciplinary, fantastic team of experts that work together to give you the best kind of care. And I'm really glad that you could visit us today here at Ronald Reagan at UCLA to talk about meningiomas. Thank you.